Good morning, good afternoon, good evening, good people. I'm going to give a talk at innovations that we did at strengthening a healthy system to try to prevent maternal deaths. And we did these two prongs. One was investigating the integration of maternal near miss audits into pre-existing maternal death surveillance and response system, and the other prong was to access how to improve access to blood um, products. So I'll be representing the teams, and I'm Luis Arangel. I'm one of the obstetrician gynecologists. Giving an overview in terms of describing what an MDSR is, as it is a continuous cycle of maternal death notification, identification, and review. And the main goal of the MDSR is to prevent future maternal deaths by learning from previous deaths. In Malawi, this system has been there since 2014, but the challenges that have been encountered with this system is that it focuses on death, and this results in a blame game situation, and service providers are demotivated, and so this weakens the quality of care initiatives that come with the process. Being aware on the challenges that the MDSR has, there is an opportunity to improve care or the quality of care that is delivered in the maternal newborn health arena, and this proposal can be done through the maternal near miss concept. So where a maternal near miss is defined as a severe life-threatening obstetric complication during pregnancy, delivery, or within 42 days of termination of the pregnancy, which the woman survives either by chance or because they receive good care at a facility. So the rationale of assessing a maternal near miss is that these cases they occur more frequently than maternal deaths, which makes it easier to track progress in the quality of service delivery. Also, surviving a maternal near miss is mainly because of the care provided, such that reviewing near misses has the potential for highlighting deficiencies and positive elements in the obstetric care of any health system. And because the mother survives, she can provide verbal details on what she experienced. The main aim of this innovation was to assess the integration of the maternal near miss case reviews within the pre-existing maternal death surveillance and response system from the three facilities in Malawi. The objectives were to establish and evaluate a process for integrating maternal near miss case reviews with MDSR activities, and also to document and disseminate insights elucidated from the maternal near miss data related specifically to the identification and management of postpartum hemorrhage. So we piloted this initiative from three facilities, where we had a tertiary facility, which is Queen Elizabeth Central Hospital, as well as the two district facilities that feed into the tertiary facility. This was an implementation science research where service providers, one, were given a refresher on the maternal death surveillance and response system, and also they were trained on the maternal near miss concept. They were trained on the criteria, on the identification, the notification, documentation, as well as the auditing component. And it was a mixed methods approach where we had qualitative as well as quantitative surveys, which were collected at 3 time points. One was the pre-implementation, then the midway through the study, and then the post-implementation. During this process, we're really trying to assess the following criteria. One, whether the service providers were comfortable and they approved the integration. Two, whether the integration was agreeable, appealing, and aligned well with the hospital priorities. Three, whether integration can be implemented. Four, whether integration can be implemented as designed. And five, whether can integration be implemented with no external support. The study period, we had about 12,000 deliveries, of which from those 12,000, 237 were near miss cases, and we encountered 63 maternal deaths. And the causes of maternal near misses, about 52% were contributed by obstetric hemorrhage, followed by hypertension disorders in pregnancy, obstetric infection, ectopic pregnancy, and anemia. On the cause of maternal deaths, actually they mirrored each other with the maternal near misses, where 27% was contribution from obstetric hemorrhage, hypertensive disorder in pregnancy next, obstetric related infection is the third, and during this time we're in the third COVID wave, so COVID related maternal deaths contribute about 8% of the entire contribution. The integration of the maternal near miss to the MDSR proposal has really influenced the formation of severe maternal outcomes group. So all those cases that were reviewed, contributors to those outcomes were grouped into three, where we had administrative factors, community patient-related factors, as well as health worker factors. From the health worker factors, the key part was the clinical acumen in deciding when to start treatment, also lack of obstetric skills, late referrals, inadequate resuscitation, and so inadequate monitoring of patients. On the implementation aspect, as we're trying to find if service providers really approved this integration process, the majority really strongly agreed and they're given their nod to say they approve, right through from the pre-implementation, during implementation, and post-implementation, as echoed by one of the clinicians who say that, yeah, so we welcomed it with both hands. As I said, it has really helped in bridging the gaps in the care that were there before. Alluded to that actually discussing a maternal death was a demotivator in the sense that it was a blame game. Our study noted that actually there's an intrinsic motivator when it comes to assessing this concept of integration, as echoed by the matron who say that actually I think integrating maternal needs into MDSI is a good strategy in the sense that at the end of whatever audit it is, you're looking to improve the quality of care. In addition, you feel better when you audit the care of a life that was saved than when you are auditing a patient who had died. So these were the sentiments coming in from service providers in terms of how motivated they are whenever they are discussing any maternal near miss. As already shown on the results section that we had about 263 maternal near misses to the 63 maternal deaths. One of the key findings really from service providers was that actually reviewing all these cases needs time. So they really pointed out that they need more adequate time for them to go through the cases. As one of the midwives really echoed to say the near misses are a bit more than the maternal deaths, so that means we need more time for auditing near miss cases. So this is a true reflection, a true opinion on what's really is happening on the ground. The team identified the near misses they've notified and going through the review process. They came out with actionable recommendations, and one of the challenges really that was noted was that some of the recommendations they are recurring in the sense that the facility has no control. Actually, it needs the national level facility system to assist in the process. And also some of the other things were the shortage of resources, mostly the blood products, as echoed by one of the in charges on the far right, who say that the only resource I can put forward is a common one, which is shortage of blood. We don't have enough blood stored in the blood bank. The objectives of the maternal near miss was to try to see how postpartum hemorrhage has contributed to this severe maternal outcome group. So the other innovation that we came out with was to check how to improve the timely access to blood products. The key interest really in this innovation was that actually access to safe blood transfusion was critical when it came to management of postpartum hemorrhage. And the other thing that we noticed that actually, apart from the challenges of chronic blood shortages, the other undocumented challenges facing women with postpartum hemorrhage when it comes to accessing blood availability within the hospital. So we had this opportunity to zoom in and try to bring out these challenges in the sense that the Malawi Blood Transfusion Services or the Ministry of Health were interested to come up with strategies to overcome these barriers and establish a more effective process to supplying blood for obstetric hemorrhage. So this study really focused on examination of blood supply and distribution in the Queen Elizabeth Central Hospital using hospital records as well as in-depth interviews. So we zoomed in to look at the distribution of the blood products within the hospital. 25% of the blood products were consumed by the Chatinka maternity unit, followed by our colleagues from pediatrics. Then we also looked at the units that came to Chatinka maternity unit. We only managed to review folders of only of 84%, and of those that we reviewed, 66% of the blood products were consumed for obstetric hemorrhage cases within the maternity unit. Already alluded to, our main interest on the in-depth interviews that we conducted was really to track the whole process from the blood donor right through to the recipient. And we had in-depth interviews with the donors, the family members, the lab techs, and anyone involved in the process of getting blood. And the final support, or the one that's received, is the recipient, as well as the overall arcing policymakers were also involved in the process. What we found as part of our recommendations from the blood access study, we managed to split the recommendations into three-level approach, where we had the national level, facility level, and at individual level. And at the national level, what really came up was there's need to have more sensitization strategies around the blood donation drives, and also explore other alternative transportation modes. In other settings, in other disciplines, they're using drones to deliver drugs. So drones can also be used to deliver blood products. They're also using motorbikes, dedicated vehicles, and all of this is done to ease on the transportation. At facility level, what we noted that was actually some of the case notes or the lab request forms were not fully filled, so regular trainings on completing blood request forms. Also, we noted that actually some of the hospital transfusion committees were non-functional, so we recommended that actually these have to be revived, revamped, and they start working. And also there should be a mechanism that actually the emergency blood products, mostly the O negative, should be readily available, and it should be easy for the units to access in case of emergency. So also notice that actually the need to explore more communication lines options between the lab, the maternity unit, and the manual blood transfusion services. At individual level, there's a need to increase the blood donor pool, so encouraging fellow members, those in the community, that they should also go for assessment for blood transfusion. From the integration process, as I said, as you noted that actually some of these actionable recommendations, they require the national level team to respond. So we recommend a responsive government machinery that has to support all the actionable points that have been raised by the Severe Maternal Outcome Committee. And also we need to institutionalize the auditing of NEMSs, and that has to come in as a quality improvement and accountability initiative, and also factoring in the additional workload as well as the time that's required in order to give or to submit an electronic full report around the Severe Maternal Outcomes group. There's also need for inclusion of community stakeholders in the MDSR committee. At the facility level, we are only at the receiving end, but most of these patients, they come from the community, so there's need for community engagement in making sure that actually the community also raises awareness around the importance of seeking urgent medical care. The other thing we noted really is that most of the time currently we do have a centralized blood bank system, where most of the district hospitals, they have to drive all the way up to come and get the blood products, which is a few, and most of the time those really won't be enough to sufficiently support the communities. So all this work that we've done really very positive, and some reasonable actions that we're going to recommend to different stakeholders. So we looked at, say, what has been the impact of this work. One key success of this work is that actually at national level, the maternal near miss concept has been adopted as a national policy. Currently, the maternal death and surveillance response teams have been given the task to incorporate the maternal near miss concept in their reviews. Also, with the works that we've done on blood access, this has brought in the revival of hospital transfusion committees, and that they should start be delegating, working in to produce results. Also coming up with a systematic blood distribution system, where it also helps in to address issues about equity when it comes to this mega blood products. So why was this process successful? So this process was successful because the stakeholders that we identified, we worked with them, or they worked with us from the word go. So we engaged them about our concept, which taught them, we gave them our plans, and we gave them frequent updates until the end of the study. And also we're working within a already existing system. So we didn't come up with any system outside the framework. It was easy for it to be adopted in. The other thing is that the feedback mechanism that we had between the two facilities, or between the researchers and the people on the ground, it was a bidirectional, and it worked very well because we gave each other real-time feedback. We've also generated interest from different stakeholders, different partners, where they want to pilot it, or they want to get their facilities to adopt to our works. So, but what we recommend is that actually there's need for training and mentoring in the new districts, and so there is also continued evaluation of this integration process, as it doesn't end only training but also on the ground in terms of how the registrars as well as most of our trainees are doing it. And also there's been an outcry about getting commitment from the different stakeholders in order to support this. I'm glad to say that actually with this issue about commitment from stakeholders, our colleagues from ONSE, they've made it a policy that since this near miss concept has been adopted at national level, they are also pushing in to make sure that actually women of relative age group, they shouldn't be left out when it comes to the blood donation drives. Colleagues, I'd like to thank you all for listening and wishing you a blessed day. Thank you.